is Barbara Cochran, and welcome to the Northwest Geriatrics Workforce Enhancement Center Geriatric Healthcare Lecture Series. Just a reminder to those of you out in the hinterlands that you should have both an evaluation sheet as well as a handout of the PowerPoint presentations from your site coordinator. If you have not filled out a profile form for this series, please do so. Continuing education credit is available, and your site coordinator should have information on how to sign up for that. And a final reminder that if you or a colleague want to view this lecture in the future, it should be posted within about 48 hours on our northwestgwec.org website. So that's nwgwec.org, and it's available for free on that website. You would not get continuing education credit by viewing it just on that website, but it's great anyway. And today I'd like to introduce Andrew Huffer. Is that how you pronounce it?
Yep.
He is a board-certified vascular neurologist at the Seattle VA, where he is the medical director of the OIG Certified Primary Stroke Center. He completed his medical school and residency at the University of Rochester and a vascular neurology fellowship at Harborview Medical Center, University of Washington. He divides his time between inpatient general neurology, outpatient stroke clinic, the VA National Telestroke Program, resident and medical school student education, and quality improvement initiatives, a very busy professional indeed. He's also the site PI for several large multi-center stroke trials, including CREST-2 and Arcadia, and he's going to talk with us today about advances in stroke treatment and prevention. Welcome, Dr. Huffer.
Thank you very much. It's good to be here, and I was given a pretty broad goal of talking about something pertinent in stroke, and so I felt like talking a little bit about some of the advances in acute treatment in particular, and then going over what the current and latest is in prevention would be a good use of our time here. I'll try to keep it pretty clinical. If something doesn't make sense, let me know. I think we're going to try to save most of the questions to the end, and of course I'd be happy to try to answer any questions you guys have along the way, if it's really a burning question. So just an outline of what we're going to be talking about today. I'll just spend a few minutes going over stroke classifications because I think that's helpful as a starting, just sort of a jumping off point in understanding why somebody's had a stroke, what type of stroke is this, and how does that help us both treat and prevent another stroke like this. We'll go over some recent advances in treatment of acute ischemic stroke. That's probably where we'll spend most of our time. Very briefly, just touch on intracerebral hemorrhage treatment and go over some of the typical evaluation we do for patients after they come in with strokes, and then just spend the rest of our time talking about general and more kind of etiology-specific prevention techniques. So starting with stroke classification, this is sort of a research tool that was developed quite a while ago, back in '93, but I think it's really useful in organizing the way I think about stroke. And so this is the TOAST criteria, or sort of the TOAST classification system. And basically, you can think of most strokes as falling into three major categories in terms of what caused them. This is ischemic stroke. And then a couple of grab bag categories that I'll go over. So the three major ones I think about are large artery atherosclerosis. So these are plaques that are in the arteries in the neck or in the brain. So typically the carotid arteries are places we tend to see these. But you can also see them any of the major intracranial vessels, particularly the middle cerebral artery, and really any of the major arteries that supply the brain. So the second category would be cardioembolic. So your kind of prototypical cardioembolic stroke would be somebody with atrial fibrillation who develops a clot in their heart, and then that breaks off and goes to the brain. But that's just one example. There are numerous other causes of cardioembolic stroke, things like valvular disease, recent MI, anything along those lines. And then the third main cause I think about is small vessel disease. So these are very different. These are basically very tiny little penetrating arteries that supply the deep structures in the brain. And usually over the years, and because of things like high blood pressure and diabetes and smoking, they can get progressively narrower and narrower and eventually just kind of block off. And these result in basically little Kuhner strokes, so very small, less than 2 centimeter strokes deep in the brain. So those are the three kind of main types of strokes. Then there's sort of grab bag categories of stroke of undetermined etiology, or other determined etiology rather. So that could be something like, dissection of one of your major arteries. So it's not because of atherosclerosis. Maybe you had a car accident and had some injury to one of those arteries. So we know what caused the stroke, but it doesn't fall into one of those other three categories. And then the last category is stroke of undetermined etiology. So that could be, for a variety of reasons, could be multiple causes. You're not quite sure which one actually caused this stroke. It could be completely negative evaluation. You'll hear that termed cryptogenic stroke. So despite doing a thorough evaluation, we never really figure it out. Unfortunately, that still makes up 30-35% of the strokes we see. Despite best practices, we just never find a good reason for why people had the stroke. And then the last category would be incomplete evaluation. So we don't really feel comfortable calling it any particular type just because we don't have enough evidence. So that was the ischemic strokes. In terms of hemorrhagic strokes, mostly what we'll focus on today is the interparenchymal, meaning the ones that occur within the brain itself. And I kind of like to think of those as being lobar, meaning they're kind of more towards the surface of the brain in the cortex or just under the cortex versus your deep bleeds. And so those tend to be in areas like the basal ganglia or the thalamus and tend to have slightly different causes. The deep ones are usually associated with high blood pressure. The more lobar ones often may have something like cerebral amyloid pathology or some other reason, vascular malformations or something else like that. And then, of course, just to round out the list, people can have subarachnoid, subdural, and epidural hemorrhages, but we're not going to talk about those today. Although subdurals in particular are of a concern to geriatric populations. All right, so moving on to acute ischemic stroke, which is the majority of what we see in a stroke practice. Probably 85% of stroke that we see is ischemic, so we'll spend most of our time talking about that. And so what's new in this area? For years, basically all we had was IV TPA or alteplase, and so that's basically a lytic agent that you can give within originally 3 hours of symptom onset. They subsequently pushed that out to 4.5 hours, and we go by basically a last known well time. That's sometimes a little tricky to establish, depends whether this was a witnessed stroke or more often than not, we see people who have sort of wake-up strokes where they're affected first thing in the morning when they wake up, and it's hard to get a good sense of exactly when the stroke might have occurred. And so when we say last known well, in that example, we would have to kind of go back to the night before when they went to bed, or maybe if they got up at some point during the night. So we can't quite pinpoint exactly when the symptoms started. And so TPA is pretty effective. Otherwise, we wouldn't use it. The numbers we like to quote, particularly when we're talking to patients, is that patients who receive IV TPA in the setting of an acute stroke are about 30% more likely to have minimal or no disability at 3 months compared to those who don't get treated. And that's pretty good. But the flip side of that is there's a risk. So it's a blood thinning agent, so it can cause bleeding. And the type of bleeding we worry about is in the brain. And so 6% of people who get treated with TPA will develop symptomatic intracranial hemorrhage. And when that happens, it's often quite a severe event. And so probably half of those patients, that may be a fatal hemorrhagic transformation. So it's not without risk. And unfortunately, despite pretty big education campaigns from the American Heart Association and other organizations, the rate of TPA utilization is still pretty low across the country. Somewhere you'll see it in sort of different numbers depending where you look, but probably no more than 5 to 10% of patients who present with acute ischemic stroke actually get treated with TPA. That's due to a variety of reasons. So probably the main one is that people just arrive too late. Stroke is a little bit unlike something like MI, which is another medical emergency, but people with heart attacks have crushing pain and they're not going to ignore that. Whereas when you have a stroke, I think there's a tendency to sort of minimize the symptoms or kind of, well, let's just wait a little while, maybe see if that goes away. Often these happen at night, so people may notice something and just sort of sleep it off and see if they're better in the morning. By that time, it's too late to treat them. There's also a number of contraindications to giving people TPA, things like recent surgery, strokes or head injuries, basically anything where we worry about the bleeding risk. And a lot of people, particularly in a more geriatric population, are on anticoagulants for a variety of reasons, whether it's AFib or DVT or something else. So that's often a contraindication to giving TPA. So for a long time, we've wanted to basically offer more. You know, what else can we do to this big population of patients who we just don't have much to offer in the acute setting? And so similar to the cardiology world, where the advent of catheter angiograms and stenting and really kind of transformed the way you view acute heart attacks, there was a lot of hope that a similar approach would work for strokes. So for the last 10, 15 years, people have been conducting trials hoping to demonstrate that going with a catheter to pull out the plaque or pull out the clot rather would result in better outcomes. And unfortunately, that just wasn't the case. Probably the best of these trials came out now about 5 years ago in 2013 called IMS3. And so that was a trial basically where everybody got TPA, and then some of the patients were randomized to thrombectomy or basically mechanical clot removal. And they unfortunately had to stop the trial early because of lack of effectiveness, and they just didn't see an improvement in the outcomes in patients who got thrombectomy. And so that could be due to a variety of reasons. Unfortunately, just because of the way they designed this trial, some of the patients went to thrombectomy without ever having vessel imaging performed. So, they came in, had a stroke syndrome, had a CT scan that didn't show any bleeding, and got treated with TPA. People thought they probably had a large vessel blockage, but they never necessarily, some patients did get vessel imaging, but a subset of the patients did not. And then they would take them to the angio suite, and lo and behold, there's no blockage of any of the major vessels. So obviously, that's not a patient who's going to benefit from a thrombectomy. There's also some question, this was sort of early in the days of the early devices for this procedure, and some question about whether those were the best devices to be using. So there was a lot of potential reasons why these trials weren't necessarily showing the outcomes we thought they would. I just wanted to kind of show you a kind of a sample outcome. Let's see if I can get this pointer going here.
It's up right there.
Oh, huh.
Hit the arrow again.
Okay, one more time.
And then, yeah, you.
Oh, yeah. Oh, sorry. Okay, there it is. So I just going to kind of go over this in a little bit more detail, just because a lot of the stroke outcome trials present their data in this form. So basically what this represents is one of the common outcome measures that we use, which is the modified Rankin scale. And it basically lines patients up on a 0 to 6 scale. Usually we're measuring this anywhere from 30 days to 90 days after an acute stroke. So 0 would be somebody has no deficits. 1 is they have some minor deficits, but it doesn't really interfere with their life. They can do everything they did before. 2 is they can't do quite everything, but they're still able to live independently. 3, they need a little bit of assistance, but they can still walk. 4, they can't really walk and need assistance with a lot more activities. 5, they're basically completely dependent. And 6, they're dead. So it's sort of it's a little bit of a coarse scale, but this is one of the common ways we look at outcomes in stroke trials. And the way that these is being displayed here is basically a treatment group and compared to basically control groups. So in this example, the thrombectomy or endovascular group versus just the TPA group. And what you want to see is more patients shifting to this lower end of the scale. So the 0s and 1s and maybe the 2s. You want to see more patients down there as opposed to up in the 4s, 5s, and 6s. And in this example from the IMS3 trial, you really don't see a dramatic shift towards the lower end of the scale. So that was sort of the disheartening result from this and the other trials like it. However, I think there were still a subset of kind of true believers, I guess you could call them, who thought there was still promise in this approach and thought that, well, maybe if we just design better trials, then we'll find what we're looking for. So some of the things that might go into a better trial I've already kind of alluded to. Number one, you want to make sure that all the patients in your trial actually have an occlusion of one of the major vessels that you could potentially pull out. So you need to confirm that with some sort of vessel imaging. Another very important concept is to establish whether there might be some salvageable brain tissue. So you'll hear this concept of a penumbra. What that basically means is, so when people have blockage of one of their major arteries, often there's sort of a core of the brain that's affected by that is probably, you can't really come back from that. That part of the brain is likely to be permanently affected. But there may be some tissue around that you could potentially save because it's kind of getting by on less blood than normal, but it's sort of managing to stay alive because of what we kind of term a collateral network. So through just sort of chance or evolution or whatever we want to call it, basically we have a good way of getting blood where it needs to go in the brain and with some backups to it. So you may be familiar with the circle of Willis, which in the brain, which kind of can help shunt blood from one part of the brain to a different part if one of the areas is kind of blocked off. You also have different collateral systems that can go from over the meninges or kind of the surface of the brain and supply some of those outer areas that it wouldn't normally supply. So some people have better collaterals than others, and those people are the ones who are probably more resistant to having an acute stroke, meaning that their brain may survive longer, and they might be better candidates to do some sort of a thrombectomy and basically buys you time to try to open up that blockage. So assessing some way to assess the penumbra might be a good component of a trial for this type of treatment. The other thing is just maybe using the best devices, the most up-to-date ones that have the best evidence for them, people who have enough familiarity with using these devices that there's not a lot of operator error. And then as with all acute stroke things, you want to make sure that you're treating patients as fast as you possibly can in every phase. So that means getting patients to the hospital faster, getting them to the CT scanner faster, giving them TPA as fast as you can. And then if you want to make a decision to go on to thrombectomy, getting into the angio suite as quickly as possible. So all of those things together may kind of help us better demonstrate an effect for these sorts of treatments. And here's just a illustration of kind of what we're talking about. So here's a couple of basically CT angiograms. On the top one here, we're looking at a coronal view, so cut kind of up and down, and this is like basically as if the person is looking at us. So this is the right middle cerebral artery here, the right anterior cerebral artery here, the right carotid artery. And you can see on the left side, you just don't see those quite as well. So that means there's a blockage of this left internal carotid artery. Down here, kind of a similar situation, but the blockage is a little bit further out in the middle cerebral artery where this arrow is pointing. So these are the type of patients who we're talking about treating with these thrombectomies. They're large vessels that are blocked off. Meaning that they're more accessible with a catheter, but also that they're supplying bigger chunks of the brain, and so there's more tissue that's kind of at risk. All right, so in terms of assessing for this viable penumbra, there's a few different ways of doing that. one of the ways, probably the most basic way we could do that is just looking at the plain CT scan that everybody gets when they come into the emergency department. There's a scoring system that some people up in Alberta came up with called the Aspect score, and basically divides the middle cerebral artery territory up into 10 different areas. And for each of those, you look at each one of those areas, and if you see some early signs of ischemia, you take away a point. So the best is to have a full score of 10. That means there's no early signs of ischemic change. As an example, on the picture on the right, this is an left MCA stroke. You can see there's a lot of change early on in this area here in particular. And so you could count up 1, 2, 3, 4, 5, 6 or 7 probably areas that all have ischemic change in them. So this patient would only have an aspect score of 3. So that tells us that a lot of the brain is not salvageable. That if we see these types of changes, then it's probably not a patient who's going to benefit a whole lot from opening up that vessel. And going even further, if we did open up that vessel, we would worry about causing actually more harm because of suddenly exposing that damaged brain to full arterial blood pressure. You might have a bleed in that area. So that's a basic, very easy way that you can kind of get a sense of whether there's viable tissue left. Another is to look at perfusion scanning. So this can be done either with CT or with an MRI. Here's an example with CT scan. On the left, we're basically looking at blood flow, and the software that they're using here, basically the purple areas here indicate that there's reduced blood flow in these particular areas. So that's probably the part of the brain that's going to be permanently damaged, and we're unlikely to be able to save that. On the right is a little bit different way of looking at it. So it's not just blood flow, but it's how long does it take blood to get to that part of the brain. You could also look at blood volume as a different way. And you can see that there's a much larger area in the green that is probably affected by this stroke. So it's taking blood longer to get here, but not all these areas may be permanently damaged. So there's a mismatch basically between the part that's going to be permanently damaged here and the part that you may be able to salvage. So this is a way that CT perfusion imaging can be helpful in selecting patients that might benefit from a procedure to remove a blood clot. And then I talked about using better devices. So probably in the last couple of years, people have shifted to using these devices called stent retrievers. Before, people had used a variety of different things, devices that looked sort of like corkscrews, or that they were just sort of like suction devices. So this one's a little bit different. It's basically a wire mesh, and you pass this up. It's kind of it's more compressed when it first goes in. There's a thin wire that goes through the clot all the way to the other side, and then you expand the mesh basically, and it presses the blood clot out against the wall of the artery. And then when you pull the mesh back, it sort of traps all of that clot in it, and it comes out with the device. So this is kind of the next generation of devices that we think may be a little bit more effective in doing this procedure. And here's an example of what we see in the angio suite. This is a conventional angiogram where, let's see here, on the left here, you have this is an so this is a little bit different than the CT scan, but they just injected dye into the right carotid artery here, so that's this big one going up. And you can see that there's a blockage in the middle cerebral artery here. They go in with the catheter and try to they deploy their stent, and you can see that this middle cerebral artery is now nice and open, and most of that territory is now being perfused. I'm not quite sure why this showed up so small, but this a similar example just with the right MCA that they pulled the clot out, and you can see the vessel now fully filling. So I think probably what you've gathered I'm hinting at is that finally we've demonstrated that this procedure actually works for acute stroke. The first trial that came out in 2015 called MR Clean, or some people call it Mr. Clean, basically was the first one to show a very convincing benefit for thrombectomy in acute stroke with large vessel occlusion. So they took 500 patients within 6 hours of last known normal, and most of them received TPA, but not all, about 90%. And most of the group that got thrombectomy did employ stent retrievers rather than an earlier device. And they found that the rate of functional independence, so the Rankin scale of 0 to 2, was at least double what it was without this procedure. So that was a pretty good outcome. Now this procedure was in the Netherlands. They did a really good job of treating most of their patients very quickly with IV TPA, so less than an hour and a half from last known well. That's pretty good time. It took a little bit longer to get the procedure done, of 260 minutes from last known well, and that's kind of an indication of that a lot of these patients, they may present to small centers where you can't do this type of procedure. So there's a lot of built-in need for rapid transportation, of getting patients to the facilities where they need to go to get something like this done. And so there's a lot of kind of hospital systems that need to be improved, and EMS care and things like that in order to make something like this feasible. And so basically within the next year, 5 more trials came out that demonstrated almost the identical thing. So very substantial benefit for this procedure. They all had more or less the same trial design. They selected their patients maybe a little bit differently. So for example, the ones where you see the biggest treatment effect, so like the Extend IA, maybe Swift.
All right, we should be back. So.
All right, sorry for the interruption. I think I was just making the point that so some of these trials basically were more selective than others, usually meaning that they would use some sort of either CT perfusion or some sort of scoring system to select the patients that had the most penumbra to save. But I think the fact remains that basically even the much less selective trials very convincingly showed a benefit to doing a thrombectomy. Almost all of these were enrolled within 6 hours of last known well. So this is kind of I don't know how familiar you are with this type of a plot, but basically the line down the middle represents there's no difference between the 2 treatment arms, and you can see that before Mr. Clean came out, all the trials were kind of right in the middle, or maybe if anything favoring medical treatment a little bit. And since then there's this 6, 7, or 8 trials that all very convincingly show that there's benefit to doing a thrombectomy. So basically, as a result of all this new information, the American Heart Association, American Stroke Association updated their guidelines to say that all patients who have a large vessel stroke with basically a pretty good pre-morbid baseline function, so meaning they weren't completely disabled before having their stroke, should receive thrombectomy preferably with a stent retriever. They're pretty broad about in the ages that might benefit from this, as long as you're older than 18. Some of the trials cut patients off at above 80, but some of the more recent trials have included patients even up to 90. So this seems to be an effective treatment in really old patients, as well as kind of your more typical 60, 70-year-old stroke patient. And again, the recommendation to treat patients within 6 hours. But like with anything, once you demonstrate that something works, people want to push the boundaries. And so what about these patients who come in after 6 hours? What about the patients who wake up with stroke symptoms? You're not sure when their last known normal time was. So in the last basically year, there have been 2 trials. One was published last year, the Dawn trial, that took those patients and actually out to 24 hours, and they still found a benefit to doing thrombectomies. And the Diffuse 3 trial, which I don't have on here because it was just presented last week at the International Stroke Conference, but again, very convincingly showed that treating patients out to 16 or 24 hours, as long as you select the patients meaning that they have some sort of a viable penumbra or healthy brain tissue that you could save, this seems to be the treatment of choice. You should treat patients with TPA, but again, those patients are only going to be the ones who arrive within the first 3 to 4.5 hours. So once you're out of that window, then this thrombectomy is really the only treatment option you have. So this is, this is all well and good. It's, I think, a very exciting thing in the world of stroke. This is the first proven treatment that we have for acute stroke in over 20 years. So there was a lot of excitement to this. But I think to take this with a little bit of a grain of salt, there's still the majority of our patients who are going to arrive. Either they don't have a large vessel occlusion, they have a small vessel stroke, or they may even still be out of the treatment window. So I think the importance, I worry a little bit that these type of data that we can still show up 16 or 20 hours or 24 hours after our stroke and still get treated. I hope that doesn't have the effect of reducing the urgency of getting people to the hospital as quickly as possible. But we'll see. So that's kind of brings me to the end of the acute ischemic stroke part. I'm going to shift gears and just talk for a few minutes about some new treatments in intracerebral hemorrhage. We don't see that nearly as often. It depends where you are, of course, but on a national level probably makes up about 15% of strokes that we see. But it's worth noting a few things that I think are kind of exciting. So whenever we see these patients coming in, and basically in this section I'm only going to be talking about intraparenchymal hemorrhages, so hemorrhages within the brain itself, rather than subarachnoids or epidurals or subdurals. But our number one goal is to minimize that whatever blood there's already there. We want to prevent that from expanding. And so there are a few things that we can try to do to help with that. So one of our main goals is to try to control people's blood pressure relatively quickly. There have been a couple trials that have looked at exactly how low we should be trying to shoot for. The biggest ones and probably best designs, we're shooting for a target of systolics less than 140. Often these patients come in with systolic blood pressures in the 180s, 190s, over 200 is not uncommon at all. So it's a pretty big drop in the blood pressure, probably more than what you would typically try to treat if somebody were just coming in with a hypertensive emergency. But in this case, we like to get pretty aggressive. And these trials didn't really find that there was improved functional outcomes, but with the big caveat that only about a third of the patients actually reached that target within the hour. So whether or not that's what we should be doing, I'm not 100% sure, but I think that that's still the practice in most places. There's no question that for people who come in on a blood thinner, like warfarin or one of the newer direct oral anticoagulants, you should reverse those as quickly as possible. For warfarin, that works really well with vitamin K and PCC or prothrombin complex concentrate, basically some clotting factors. You can usually reverse the effect within 20 or 30 minutes. There's now a direct reversal agent for dabigatran, which is one of the newer agents. So this is an antibody that directly binds to the dabigatran and gets rid of the effect within, again, about 20 to 30 minutes. For the other ones, the apixaban and rivaroxaban and doxaban, we don't have direct ways to reverse their effects, but there are inhibitors kind of in development. So those probably within the next few years, those will be available. The question has been raised a number of times in the last 5-10 years about, well, what about patients who aren't taking a blood thinner? Should we be trying to give them something to stop bleeding a little more quickly? And probably the biggest trial here was looking at factor 7A, which is part of your clotting cascade. And while it did reduce the growth of the hematoma, it didn't really show any improvements in outcomes. And part of that was because there were a lot more thromboembolic events in the treatment groups, meaning that they were getting heart attacks and strokes and DVTs and PEs and all the things you might expect if you're giving somebody a pro-clotting agent. So that kind of more than offsets any benefit you might get from the treatment. So as of right now, we don't have anything that we know will work for patients who are not taking blood thinners. But a number of trials still ongoing. One of the things we look for when people come into the hospital is something called a spot sign. So this is basically a finding on the CT scan, specifically the post-contrast CT, where you can see, so blood shows up as bright on a CT scan. So here you can see, right, this is kind of like a, thalamic or internal capsule stroke, basically. On the post-contrast images, you can see this little bright spot at the kind of periphery of that hematoma. And there's been pretty good evidence that seeing that correlates to the ongoing bleeding. So those are the types of patients who we really worry about that bleeding getting worse. Eventually, the bleeding usually stops because there's only a finite amount of space within the skull. So the pressure builds up, and eventually it kind of tamponades itself off. But you don't want to sort of wait for that to happen. So we worry about when we see something like the spot sign that this is the type of bleed that can grow quite a bit more. So I think the natural question is, well, if you're seeing blood and you don't want it to grow, should we just take the blood out with doing a surgery? And there have been a few studies that have looked at that. And really, there haven't been obvious benefit there. I think part of it has to do with, doing a big craniotomy, cutting a big skull flap, and then doing an invasive brain surgery carries a lot of morbidity and mortality associated with the procedure itself. So it's pretty hard to demonstrate that that's going to change the outcomes all that much. There's maybe a hint that the patients with lobar hemorrhage, so ones that are closer to the surface, might do better with this type of approach, but overall there's not been great evidence for this. So I think more and more we're interested in doing minimally invasive surgeries, where instead of doing a big craniotomy and an open surgery, we'll just do a stereotactic guided procedure where they put a very thin kind of device directed exactly to the center of the clot, and then using a kind of a combination of suction and even sometimes injecting a little bit of TPA locally where that blood clot is, they can try to get out most of the blood from that area. And so these are just a couple of examples of that. So here's a pretty large bleed here that you can kind of get a sense of where the track was. So it was probably came in from the left posterior part, and there's just a little bit of blood left there. So quite a bit less invasive. We don't totally know that this works yet. The kind of preliminary trials, the phase 1 seems to suggest that this is a safe and maybe effective procedure, but there's a bigger phase 3 trial called MISTY that's ongoing, and we should know more within the next couple of years. So that's all I'm going to say about intracerebral hemorrhage. Again, we don't encounter it quite as often. It tends to be more devastating, and so we're still kind of looking for better ways to treat that, I would say. So now I'm going to kind of shift focus back to ischemic stroke and talk about just briefly how we evaluate these patients when they're in the hospital. We try to get a lot of testing done within a short time window just to try to find if there are any smoking guns that could explain why this person had a stroke. The reason we do that is because the highest risk of having another stroke is within that first, couple of months, but really it's within the first probably 1 to 2 weeks. So if we can identify something like atrial fibrillation or a tight carotid stenosis early on, we have a much better chance of being able to prevent another stroke from happening. And that, while you could argue, well, we're not doing much about the original stroke, that may be true other than rehab, but there's no question that having another stroke on top of that is going to make this person's quality of life even worse. So I put together a little table that kind of goes through what I would consider kind of routine evaluations, and then more of an extended evaluation that you may do in unusual circumstances. So everybody's going to get some sort of brain imaging, particularly a CT scan. Almost everybody will get an MRI as well, depending on where you are in the resources. There's not a whole lot of additional brain imaging. I guess every so often, maybe you'd see a particular type of MRI called SPECT, where you can get a sense of, basically the only time we would get something like this is if there's a question of whether we're seeing a stroke or a tumor or something else. And so a SPECT MRI can sometimes help us differentiate that. But I don't know that I've ever actually ordered one of those. We want to get some sense of what the blood vessels are, both in the neck as well as within the brain. The carotid ultrasound has kind of been the old go-to for that, but it only gives us a picture of what's going on in the carotids. CTs or MRAs are both good ways to look at the intracranial vessels. I think my experience is that CTAs probably have a little bit better resolution. But you're giving somebody a contrast load, so if they have renal dysfunction or something like that, sometimes it's not possible. Whereas MRAs, and there's also radiation. Whereas MRAs, there's no radiation, and you can do it without giving contrast, which is kind of nice. Rarely, if you're worried about something like vasculitis or some other rare cause of stroke, we may get a conventional angiogram. DSA stands for digital subtraction angiography. In case you're confused by that. We usually want to get a picture of the heart and see if there could be something structural going on there. Looking for things like patent foramen ovale, looking for valve problems, vegetations on one of the valves, looking for a part of the wall that's not moving too well, looking at the ejection fraction, atrial enlargement. There's a variety of things we can look for there. Transthoracic echocardiogram is probably the go-to approach. Sometimes we'll ask the cardiologist to do a transesophageal echo if there's some particular concern for something like, if we're worried there's a clot in the left atrial appendage. That's an area that the transthoracic echo doesn't see very well. Or if we're worried about the aortic arch, that's another thing that transesophageal echo does a better job at seeing. A lot of strokes, particularly as patients get older, are caused by rhythm abnormalities, particularly atrial fibrillation. So everybody who comes in should get an EKG. And typically when they're admitted to the hospital, they get telemetry for at least 24 to 48 hours. If there's a strong suspicion that somebody's stroke is embolic from a cardiac source, then most of the time we'll send them out on some sort of an extended heart rhythm monitor. So there's different forms of this. A Zio patch is something we use at the VA. It's a 2-week monitor, basically a patch that has the electrodes all built into it, so you don't have to worry about placing a bunch of different leads. You'll also just see event monitors that you can run for as long as 30 days. And then rarely, if we're really suspicious but we just can't prove it, what we're looking for, we'll send people for implantable loop recorders. And these are just little kind of thumb drive size devices that just go subcutaneously in the chest and can monitor the heart rhythms for up to several years if we need them to. Periodically, it'll just sort of transmit the data to the cardiologists. Routine laboratory studies we usually get would be kind of your basic CBC, metabolic profile. We usually check lipids, although I don't know, some of you may have read some of the bulletins from the American Heart Association. They recently just revised their recommendations for some of these secondary or these diagnostic workup tests, and actually said that there's really no evidence that you should be doing some of these things because it doesn't directly lead to change in your management. But I think most people are not going to change what they do dramatically. And so lipids is one of the examples where they said, well, everybody who's had a stroke should be placed on a statin, so there's no need to check lipids anymore. I think that's going to be a hard habit for a lot of neurologists to break, but we'll see. We screen for diabetes, usually with an hemoglobin A1C. You can argue that maybe that's not the best screening test for diabetes, but that's what we use in neurology generally. And then we'll often check a BNP, or brain natriuretic peptide, which can go along with heart failure, but can also be seen elevated in the setting of atrial fibrillation, even if somebody doesn't have a known history. So that's a good reason to look at that. In patients who are younger, in their 30s, and you don't have a great explanation for why they had strokes, often we'll do a broader laboratory screen for things that might be associated with increased risk of forming clots. So things like inflammatory markers, factor V Leiden, genetic predispositions to forming clots, but we don't get these routinely in all of our patients. Just as an example of why we do some of these tests, this is taken from a paper that came out a few years ago looking at extended heart rhythm monitoring in stroke patients. So they basically took patients who had embolic-looking strokes where there was some suspicion that maybe a clot could have started in the heart, and they put implantable loop recorders in them and basically just reported what percentage of the patients turned out to have AFib over time. And so you can see that in the first 6 months, there was 7 or 8% of that group ended up being diagnosed with atrial fibrillation. By a year, that had increased to about 13%. At 3 years, that was up to 30%. So a lot of these patients who don't have known atrial fibrillation but have embolic-looking strokes, if you monitor them long enough, you may find that they're going in and out of atrial fibrillation, and it's just a matter of you're not getting enough of a sample. So if you look for it, oftentimes you'll find it. All right, so moving on from our evaluation phase to then, okay, now we've found something, or maybe we haven't found something. What do we do to try to prevent this person from having another stroke? So I think we can divide this into kind of general measures that everybody who's had a stroke should get, and then maybe more some etiology-specific measures that would be a little bit more particular to certain patients. So as much as we get excited about devices and interventions and things like that, I think it's really important to remember that most of stroke risk is explained by modifiable risk factors. And so you can't forget these things like diet and exercise and smoking cessation. Even though they're not sexy and nobody wants to talk about them, you still have to, because honestly, probably if you want bang for the buck, that's the way you should really focus your attention. So one of the issues, I think, and particularly things like diet and exercise, is we have kind of conflicting or messy data and what to really recommend to people. And everybody comes in probably with some sort of an idea from their own reading or from talking to friends or family about what diet they should be on. And there's just so much conflicting information flying around. It's often very hard to break people's practices. So things that we know are associated with lower risk of stroke are low sodium diets. So that's been pretty well proven. That's probably mediated because of its effect on blood pressure control, and blood pressure is probably the #1 modifiable risk factor for stroke. Vegetarians on average have lower rates of stroke. Vegans do as well, but in particular, they've done kind of population-based studies on Seventh-day Adventists and some of these other religious groups that tend to follow a vegetarian diet, and they without question have lower rates of stroke and other cardiovascular disease. Actually, the Mediterranean diet probably has the best randomized evidence for it. So this is the only as far as I'm aware, this is the only trial that's been done looking at secondary stroke prevention. So it only enrolled patients who'd already had a stroke, and basically, this was done in Spain, randomized them to either Mediterranean diet with a lot of kind of dietary counseling and things like that, versus just whatever they were eating already. Now, a lot of the patients were already sort of eating a modified Mediterranean diet to begin with, but the groups that were in treatment arm either got some absurd amount of olive oil that was given to them by the trial, like it was like a liter a week or something like that, or they were given a comparably large amount of nuts to eat. So those are considered the treatment trial. So I guess the biggest difference you might say would be the ratio of these maybe healthier fats. And what they found was that there was a modest but significant reduction in secondary stroke rates in the treatment groups. So that's probably the best evidence we have for secondary stroke prevention. I think a lot of these things like the DASH and Mediterranean generally probably work as well as each other, but we don't have great ways of comparing them necessarily. I think the low-fat diet has kind of fallen out of favor a little bit, and I think that's probably all I'll say about that. There is not very good evidence for specific micronutrients, and by that I mean things like vitamin D, folic acid, any of these types of things. They've done a number of trials that have looked at supplementation with these, and none of them have consistently shown any reduction in stroke risk. So while there may be reason for people to be supplementing with some of those things, I don't counsel patients that they need to start folic acid or something like that after they had a stroke, because there's just not enough evidence for it. Exercise is kind of similarly fraught. I think the traditional recommendation has been 5 or 6 days a week of low to moderate intensity exercise. I think 30 to 60 minutes a day or something like that. I think there's probably a fair amount of competing evidence that maybe moderate to high intensity, even if it's done a little bit less frequently, may have similar benefits. But again, this has not necessarily been specifically studied in secondary stroke prevention. So if you can encourage your patients to be active consistently, I think that's a win. But again, kind of hard to do. Smoking, kind of a no-brainer, but I think that it bears repeating. The risk of stroke in smokers is about 3 times that of non-smokers, and even for former smokers, it's still about 30% higher. But the good news is that within 2 to 4 years of quitting, your risk goes back down to kind of a population average. So there's good reasons, even in your kind of recalcitrant lifelong smokers, that it's not too late for them to at least try to improve their cardiovascular health by quitting. I can tell you that is a tough sell at the VA, but I do my best. All right, so blood pressure. That is probably, as I said, the number one modifiable risk factor. We think about this in sort of different phases. So you may have come across patients who, in the setting of just being admitted for an acute stroke, where we're talking about allowing for permissive hypertension. So allowing their blood pressure to run a little bit higher. And that we understand that as basically the body's way of promoting perfusion to the brain, particularly if an artery is not open anymore or is significantly narrowed. So the timing of that, anywhere from 2 to 4 or 5 days will usually allow permissive hypertension. Some of it depends a little bit on the stroke mechanism. So for these small vessel strokes, sometimes I'll start treating the blood pressure a little bit sooner. Whereas if somebody has a very large artery, like a carotid or a middle cerebral artery, or that's very narrow, sometimes any small reductions in the blood pressure is enough to cause new symptoms to come up. So you have to be a little bit more gentle about lowering their blood pressure over time. Long term, there's no question everybody does better if you lower their blood pressure. Used to be, we would say 140/80 unless you were diabetic or had some sort of cardiovascular equivalent. Probably based on the new AHA guidelines, that should be revised downward to 130/80. That seems to be borne out in a trial that was done a few years ago called the SPS3 trial, where they looked at patients with small vessel stroke, and the group that got randomized to the tighter blood pressure control seemed to do a little bit better. I think probably just as equally important as reducing the blood pressure is to try to reduce variability. This is particularly important kind of in the early phase after stroke. So you don't want big fluctuations going from hypertensive down to relatively hypotensive. You'd rather have people kind of relatively sort of normotensive for the most part. The agents that probably have the best evidence in a stroke realm in particular include some of the calcium channel blockers, particularly amlodipine, non-loop diuretics like chlorthalidone, and the ACE inhibitors or ARBs. So those are probably my three first-line agents if I have to start somebody on something new. You know, a lot of people have reasons to be on a beta blocker or something else if they have other comorbidities, but these are the ones if I have no other reason to start something. So lipid control, we have pretty good randomized data that lowering people's lipids with pretty aggressively does reduce their risk of stroke. So the Sparkle trial, this was more than 12 years ago now, that came out with a very large trial of almost 5,000 patients with an LDL of greater than 100, randomized to high dose atorvastatin versus placebo after their first stroke. And on average, the treatment group, as you would expect, ended up with about 50% of the blood pressure or of the LDL of the placebo group, and the stroke rates were sort of modestly lower, 11.2% versus 13.1% at 5 years. It's a big enough trial that reached statistical significance. So you might see those numbers and not be all that impressed, but I think in secondary stroke prevention, that's relatively impressive, I guess I would say. So we've gone away a little bit from looking at just a pure numbers approach. It used to be that we would say, well, if your LDL is greater than 100, then you should be on a high intensity statin. Or if you're diabetic and have coronary disease, then we need to get you below 70. So I think now, if anybody who comes in with a stroke thought to be related to atherosclerotic disease, either large or small vessel, they should be on a high potency statin, kind of regardless of their numbers. And if it's a cardioembolic stroke and they have totally pristine vessels and it's a younger patient, I'm not so sure that I would start a high potency statin. But I think this is where some people's approaches kind of differ from each other. There are some newer agents on the market in a totally different class that are definitely reduce people's cholesterol a lot. It's a little bit unclear whether or not they're going to reduce people's stroke risks. I'm going to skip over this for now. These work by a very different mechanism than your statins, but I'm not sure they're quite mainstream or ready for prime time yet. So diabetes, basically there's really weak recommendations from the American Stroke Association about what to do about diabetes. All they say is that you should screen for diabetes in all patients with a hemoglobin A1C, and then follow the American Diabetic Association guidelines for management. So they don't really tell us specifically how to treat people's diabetes, but kind of an interesting trial that came out a couple years ago called the IRIS trial basically looked at patients who may not have actually had diabetes, but were probably somewhat pre-diabetic or at least had insulin resistance, and randomized and they had a recent stroke, and they randomized them to a pioglitazone versus placebo, and so that's kind of it reduces insulin resistance. And then they looked at long-term outcomes in terms of secondary strokes or heart attacks. And actually, pioglitazone did just about as well as statins do. So reduced it by almost 3% at 5 years. and with a similar number needed to treat. The problem is, oh, and it also sort of prevented a lot of these patients from developing diabetes compared to a placebo group. But the problem is, it's not quite as tolerable a medication as you'd like, so results in a lot of weight gain and osteopenia and fractures. So I think it's not a real popular diabetes drug, but they're kind of doing similar trials now with some of the other agents like metformin and some others. And so we'll see if this is a new area that we'll routinely be focusing on after stroke, even in patients who may not meet criteria for diabetes yet. So I think one of the biggest questions I get as a stroke neurologist is, or maybe a source of confusion among a lot of people, is what kind of antiplatelet agents people should be on. Is it aspirin? Is it clopidogrel? Is it Agrinox, or some combination of these? And I think I don't know, for whatever reason, we've made this needlessly complicated. I guess the summary is that there's probably not much difference between any of them. There's no question that you should probably be on an antiplatelet agent unless you have some indication for, like atrial fibrillation, for anticoagulation. But what you choose probably doesn't matter all that much. So I'll just kind of briefly go through some of the trials with this. So Capri basically looked at aspirin versus clopidogrel or Plavix in patients who'd had a recent cardiovascular event, either a stroke, heart attack, or peripheral vascular disease, and basically found that there was a slight reduction in secondary events, but most of that was driven by the peripheral vascular disease group. So if you just look at the stroke patients, there's probably not a huge difference between aspirin and Plavix. Match came along about 8 years later and looked at patients with recent strokes and randomized them to aspirin versus a combination of aspirin and Plavix, and found at 18 months there was no difference in secondary stroke rates, but there was a higher risk of bleeding in the patients who were taking 2 antiplatelet agents, which is not necessarily surprising. SPS3 looked at a similar, basically did the same thing, except they were specifically looking at patients with small vessel strokes, so lacunar strokes, and they found the same result. There's no difference in the secondary stroke, but there is an increased risk of bleeding. So you probably shouldn't put people on combined antiplatelets long term because it doesn't help them that much and it causes more bleeding. What about short-term dual antiplatelets? So this is something you may see fairly often. So there have been a couple of trials. Chance is probably the best one, that looked at patients with recent strokes and just put them on dual antiplatelets for 3 weeks. And after that, they just went on single therapy with either aspirin or Plavix. And they did find that there was an improved outcome with the group that had received dual antiplatelets. But this was almost entirely done in a mostly a Chinese population, and they have much higher rates of intracranial stenosis in Asian populations for whatever reason. And there's some suggestion that those types of patients might do better with dual antiplatelets compared to a general population. So we don't know if this is broadly applicable. There's a trial that's still going on called Point that we should see results, I think, within the next year or so. So we'll see if that proves to be the case. But I think a lot of stroke neurologists will at least temporarily put patients on dual antiplatelets for anywhere from a few weeks up to a couple months, and then switch them back to just a single agent after that. I'm going to skip over the stuff about some of the other agents like Agrinox and ticagrelor and taclopidine. There's a number of other things that people will get switched to, usually if they have, quote, failed aspirin or Plavix. But I think that whole concept of treatment failure is a little bit overused. Any of these antiplatelet agents reduce your risk of stroke. They don't get rid of your risk of stroke. So it's expected that a certain number of patients taking those medications are going to have strokes. And I'm not sure that necessarily means we need to be switching everybody around. There's certainly no evidence for that. So my approach usually after non-cardioembolic stroke, so if I'm not concerned somebody has atrial fibrillation, if they haven't been taking aspirin or any other antiplatelet agents, I'll usually start them on a baby aspirin. There's really no evidence that baby aspirin is any different than full dose. If they're already taking an antiplatelet, I'll often put them on dual antiplatelets for anywhere from 3 weeks to a couple of months, and then we'll reduce them to a single agent after that. So I think people make this very complicated and doesn't necessarily need to be so complicated. As I said, I think the focusing on weight loss, exercise, and diet probably has a much bigger impact than which antiplatelet agent you choose. So finally, I'll close with just some comments about some of the specific conditions that we see that may have different secondary prevention associated with them. So with large artery atherosclerosis, so if it's in particular in talking about carotid stenosis, so we like to differentiate between symptomatic carotid stenosis and asymptomatic carotid stenosis, meaning symptomatic, basically if they've had a TIA or a stroke related to that narrowing, so in other words, affecting the same side within the last 6 months, we would consider that symptomatic. There's no question that group of patients benefits from opening up the vessel, either with an endarterectomy or with a stent, and particularly if that narrowing is greater than 70%. If it's between 50 and 70%, there's a little bit less benefit, but there's still probably benefit. And you get the biggest bang for the buck if you perform the procedure within 2 weeks of them presenting with their stroke or TIA. After that, the benefit tends to drop pretty quickly. If they're asymptomatic, so if, they go to their primary care's office and somebody picks up a bruit, or they just happen to get a carotid ultrasound and they find that there's 70% narrowing of one of the carotids, then the data would suggest that those patients should also get an endarterectomy or stenting, but that data is pretty old now, and it was the trials were mostly done in an era where not that many patients took statins, a lot more patients smoked, and not everybody even took aspirin or an antiplatelet agent regularly. So it's not really clear that we should still be operating on all of these asymptomatic patients. So there is a big trial that's ongoing right now called the CREST-2 trial that's trying to answer that question, specifically for asymptomatic patients, whether doing an endarterectomy or stenting or just doing medical management makes the most sense. So we won't know the results of that for another few years probably. In terms of which procedure to do, endarterectomy or stenting, there are a few factors that might influence that decision. I guess the things that might push you, they're mostly kind of anatomic. So the factors that might push you to do endarterectomy would include having a lot of plaque in the aorta. So when they do a stent, they have to put a catheter up and across the aortic arch. There's a big risk that you're going to knock off plaques when you do calcifications when you do that, so you could cause a stroke. So if there's a lot of plaque in the arch, you probably should be doing an endarterectomy. If they have sort of funny anatomy, we see a lot of variant anatomy off of the aortic arch, and so if it's at all unusual, often we'll favor an endarterectomy. And for whatever reason, older patients tend to do better with endarterectomies as well. That's kind of counterintuitive because it's it's an invasive procedure. They have to be put under general anesthesia. So we had just assumed that the older patients would do better with stenting, but the original CREST trial that was published in 2010 actually found that older patients seem to do better with endarterectomies. So just a little diagram of what they do with an endarterectomy is basically they cut open the artery, actually pull out the plaque manually and suture it back up. It's pretty straightforward. So some of the factors that favor stenting include if you've had a previous endarterectomy, if you've had radiation to the head or neck, if your narrowing is further up in the carotid, so closer to the jaw. It's sometimes hard to get at with an open surgery, and younger patients tend to do better with stenting. So that's carotid disease. Intracranial atherosclerosis. So basically, I kind of alluded to this already, but basically these are the patients who may do better with dual antiplatelet therapy for at least a few months. So typically we'll treat these patients for about 3 months with dual antiplatelet therapy and then lower to just a single agent. We very aggressively treat their blood pressure and we very aggressively treat their cholesterol. All this comes out sort of as an accident from this trial called SAMPRIS that was published in 2011, where they wanted to show that stenting these patients with intracranial stenosis was a good idea. And they actually had to stop the trial early because their placebo arm, which just got medical therapy, did so much better than the stenting arm. And there were a lot of deaths and strokes that were being caused by the stenting, so they actually had to stop it early. And out of that protocol, basically, that's how we now treat intracranial stenosis. So kind of a fortuitous discovery in a way. So for cardioembolic strokes, atrial fibrillation, there's no question that those patients do better on anticoagulation compared to antiplatelet agents. It used to be that everybody would be put on warfarin, but as you know, that's a somewhat difficult drug to use. You have to get your INR checked every week or 2 weeks, and some people just have a hard time with it. So I think we're in an era now that most people are probably starting to switch over to these newer agents like dabigatran, rivaroxaban, and apixaban. They have all basically been shown to at least be non-inferior to warfarin, meaning that they work just as well to prevent strokes. Apixaban specifically is superior to warfarin to prevent strokes, and they all tend to be slightly safer as well, so they have lower rates of bleeding associated with them. There are some kind of intricacies to each one that might determine which one you would choose, but they're all pretty comparable. The biggest downside, I think, has been that up until pretty recently, they don't have specific ways of reversing them. So if you develop bleeding while on them, that can potentially be a problem, whereas you can quickly reverse warfarin. That's not totally true anymore. As I mentioned earlier in the talk, the dabigatran now does have a specific reversal agent, and probably within the next couple of years, the other ones will as well. So hopefully that's not as big a concern. I'm going to skip this. So the other another big source of cardioembolic stroke is this concept of a patent foramen ovale, where if you get a venous clot, it could cross the PFO and go directly to the brain. We see these in 20 to 30% of the population as a normal variant, and most of the time it doesn't cause any problem. But if somebody has a otherwise unexplained stroke, and particularly if it's a younger patient, if it's a good story like they've been on a plane flight recently or a long drive, or if they've had some sort of a leg injury or trauma or something like that, then sometimes we do consider this as a possible cause. It used to be that everybody who had a stroke and was discovered to have a PFO would get it closed. The way they do that is basically going in with a catheter through the groin. They put the catheter across the septum, and they deploy this device that basically kind of has a piece on both sides that kind of smooshes together and closes the hole off. So it's a pretty straightforward procedure. It has some risks associated with it. You could cause a stroke, rarely. People often can actually flip into atrial fibrillation either during or after this procedure. So there's some thought that, well, maybe that could increase the risk of stroke as well. So it's not completely benign, but pretty well tolerated procedure. And for a long time, they tried to demonstrate that this reduced stroke risk, and they just couldn't do it. So all these big randomized clinical trials just didn't show any benefit until pretty recently. Actually, one of them, the RESPECT trial, finally, with 6 years of follow-up data, demonstrated sort of a modest reduction in secondary stroke risks. So I think we're still a little bit in limbo as far as what to do about PFOs when we discover them. The general approach would be if somebody has some high-risk features associated with the PFO, so those would be like a very large PFO, or if there's an aneurysm, so we call them atrial septal aneurysm that's associated with a PFO, then those patients might do better by closing it. Or if they're a very young patient, say less than 50, and don't have other obvious stroke risk factors, but they're going to live a long time, so their risk of stroke is going to kind of accumulate over time. Those might be patients you'd think about closing it. Whereas if you have an 80-year-old with a lot of, carotid plaque and a lot of other, and is a smoker and a lot of other traditional cardiovascular risk factors, it's less likely that the PFO was the main cause of his stroke. If that were going to contribute, it probably would have happened earlier in life. So I think we sort of age stratify patients a little bit in considering whether or not to close their PFOs. I guess I'll just briefly mention this other concept. So this is another potential source of cardioembolic stroke. So one of the things that we've found out is that even patients without atrial fibrillation still can have strokes that look very much like an embolic stroke that people with atrial fibrillation have. And they may have markers that kind of go along with that. So they may have an elevated BNP, or if you get an echocardiogram, they may have an enlarged atrium. So they look for all the world like somebody who has atrial fibrillation and had a stroke, but they just don't have AFib. And so there's this concept of kind of atrial cardiopathy, where there's something about the atrial fibrillation is not what causes stroke. It's something about the atrium that predisposes you to having atrial fibrillation that also increases your risk of having stroke. So there's been a lot of interest in this area in the last couple of years. There have been a couple of studies that have been designed based on this concept, and I just wanted to mention one that's coming up called the Arcadia trial, where basically somebody who recently had a stroke that looks embolic will be randomized to an anticoagulant, so like a Pixaban, versus aspirin, with the thought that some of these patients will do better on an anticoagulant because they have something wrong with their atrium, even if we're not seeing atrial fibrillation right now. So we'll see if that proves to be true or not. But I think it's kind of one of those areas that's it's sort of exciting in the stroke world right now. And then just very briefly, there's some other kind of much rarer causes of strokes, like dissection of the carotid or vertebral arteries. For a long time, we would put those patients on heparin or anticoagulation, but there's really not much evidence that does a better job of preventing strokes than antiplatelets. So I think that's probably falling out of favor a bit. People who are younger who may have increased clotting risk or hypercoagulable states, I think probably the most relevant one to be aware of is antiphospholipid antibody syndrome, often associated with lupus. But when people have this, they probably should be anticoagulated because they're at really high risk of having other cardiovascular events, both strokes and heart attacks. People with vasculitis, we generally treat with a combination of aspirin or any immunosuppression. Patients with sickle cell disease, in addition to your sort of typical stroke management, they also really benefit from doing exchange transfusions to reduce the percentage of sort of sickled cells that they have that contribute to their strokes. And then there's very, very rare stroke syndromes like Moya-Moya and CADASIL, which I don't think are probably beyond the scope of this talk. So just to summarize all that, we've covered a lot of ground. I think the big exciting thing in acute ischemic stroke is endovascular thrombectomy. It's very effective, but I think it's important to remember that majority of patients we're treating are still not going to be candidates for this treatment, and so time is still the essence. So getting patients to the hospital fast, getting them treated fast with TPA if they're candidates, and just not forgetting that part of it in this sort of new era of interventions. Treatment of spontaneous intracranial hemorrhage should focus on limiting the expansion of the hematoma by doing things like controlling blood pressure if they're on an anticoagulant, rapidly reversing that effect, and maybe we should be considering minimally invasive surgical interventions to remove the hematoma. in terms of the diagnostic evaluation, we should be thorough, but I think we should be thoughtful and not just kind of blindly order every test in the book, but understand the pattern of the stroke that the patient has and order our tests based on that to try to increase the chance of finding something that we could do something about. And then just finally, in terms of prevention, so there's a subset of stroke patients who may benefit from specific treatments like carotid endarterectomy or, PFO closure, but everybody you see with stroke can benefit from reversible risk factor reduction, including counseling on diet and exercise and smoking cessation. So I think with that, I am happy to take any questions from the room or afar.
Okay, so I've got someone who's asking if you would please go over. Did I not? Oh, no, I did.
Oh, okay.
Asking if you would please go over time of anticoagulation slide.
This one?
Not working?
Sorry, you can answer his question.
So the question,
Yes.
assume this is the question?
I'm assuming.
Yeah, so I just skipped over this just very briefly. So when patients come in with a stroke and they're found to be in atrial fibrillation, we often don't immediately start them on warfarin or an anticoagulant because the risk of having a hemorrhagic conversion is fairly significant. So often we'll just wait 2 weeks before doing that, and in that time, treating with aspirin is reasonable. I skipped over that because, it wasn't super relevant.
And we're getting a question, if a patient is already on anticoagulation for AFib, but stroke looks cooner or large vessel, do they benefit from aspirin?
Yeah, that's a really good question. So I rarely will add aspirin to an anticoagulant. There's some thought that large vessel athero does better with an antiplatelet agent compared to an anticoagulant. So if it were a large vessel from carotid and they happen to have atrial fibrillation, they should still get a carotid endarterectomy or treatment specifically targeted at that. I almost never add aspirin to an anticoagulant, though. Most of the time, if we see that combination, it's because they have coronary disease as well, and the cardiologists want them to be on aspirin to prevent heart attacks. So I think that the risk of bleeding pretty quickly outweighs any additional benefit you get from adding another agent.
And here's another aspirin question from Port Angeles. What is your recommendation for continuing or discontinuing aspirin 81 milligrams daily in older than 70-year-old with a history of TIA more than 5 years ago? Aspirin would be stopped for primary prevention for MI, but what about the TIA? Does stopping aspirin increase the risk of CVA?
Yeah, that's a good question. I don't know that we have any data that's that long-term follow-up. That we generally recommend indefinite continuation of an aspirin or whatever antiplatelet agent they're on. But I think patients that age do tend to accumulate other things like falls and GI bleeds, and if there's anything that sort of tips the balance in that direction, then I would have probably a pretty low threshold to stop aspirin.
Can you please address post-stroke depression risks, treatments?
Yeah, sure. So post-stroke depression is really, really common. It's probably 50 to 60% of stroke patients will suffer from some degree of that. It's something that stroke rehab docs often deal with more, but I see it in my clinic as well. And there's pretty good evidence that treating with an SSRI, at least in the short term, can be effective. There's also a trial that came out a few years ago called the FLAME trial that suggested that SSRIs, particularly the one they studied was fluoxetine, actually improves motor recovery after stroke. So not just post-stroke depression, but for whatever reason helps neuroplasticity or something. I think it's kind of hand-waving at this point, but the patients who were randomized to fluoxetine improved their motor function in their arm more than the other group did. So yeah, we treat that very frequently.
Do we have any questions in the room? Oh, okay, here. What is your perspective management on the clinical significance of the drug interaction between can't remember how to pronounce this, clopidogrel as prodrug and omeprazole,
Yeah.
inhibition of prodrug activation, and instances of when to use pharmacogenetic testing for
Clopidogrel, yeah.
yeah, sorry, response.
Yeah, so I forget the percentage that omeprazole is supposed to reduce the kind of availability of clopidogrel. It's something like 30 or 40%. So that's potentially relevant. You'll see patients, providers checking a P2Y12 assay not infrequently just to see how well clopidogrel is inhibiting platelets. I don't use it all that often, to be perfectly honest. And I think part of the reason is I tend to think that there's a fair amount of equivalence between the different antiplatelet agents, as I mentioned. And so, if I guess if there's a concern that between of drug interactions with clopidogrel, I'm likely to switch somebody back to aspirin, even if they've already been on it, and maybe even if they've had a stroke on aspirin before. Yeah, so that's a tricky question. I mean, there's also interactions between SSRIs and clopidogrel, maybe not quite to that extent, but that question does come up pretty frequently.
Okay, I think we're done. Thank you so much.
Of course, thank you.